So I would like now to introduce the next plenary speaker, who is Stephen NIEDERER, professor at the School of Biomedical Engineering and Imaging Sciences at King's College London. Professor NIEDERER is well known in the community of heart modeling. His research combined, let's say, clinical data with biophysical computational models of the heart. And to just cite one of his achievements, he recently received as well a prestigious grant from the European Community to develop virtual heart models. So we look forward for your lecture. Professor NIEDERER, the floor is yours. Thank you. I think you should activate your microphone. We still don't hear you.
I see Professor NIEDERER has the microphone on, so maybe the problem is another one.
And how's this?
Okay, great. We hear you.
Excellent. So the top of my talk is really looking at some of the work that we've been doing about using simulations to get a better understanding of cardiac synchronization therapy, which is treatment for heart failure. And we're really interested in trying to work out how to deliver the right device to the right patients at the right location. How can we use computer models to do this? So like everyone, we view the heart as a multi-scale and multi-physics problem. We start off with activation patterns, which are going to start in the right atria, propagating through to the left atria for activating the left and right ventricles. We can link this through into cellular models, which are going to represent the movement of ions in and out of the cell and the kinetics of proteins which are spanning the cell membrane to deliver that electrical current at the cell model. These cell models then give rise to a calcium transient, calcium signal, which is going to be transduced through to the sarcomeres, where calciums are going to bind to the thin filaments, allowing thick filaments to bind, causing contraction at the cell scale. The cells are going to contract within a tissue structure, and depending on the collagen and the makeup of the structure, this will determine the stiffness of the material as well as the anisotropy. The deformation of the cells will then manifest themselves through that tissue and the anatomy of the heart to give rise to deformation within the whole heart. And increasingly, we're now looking at how this deformation or this motion that we're seeing in the whole heart will give rise to changes in the fluid dynamics leading to these CFD simulations we've been doing with Elias at the University of Graz. So this all comes together and takes a remarkable amount of software. We have CARP that we work with Gernot and Ed. We have CMerge, CMerge app, which is the software from our group, which we use for making the models. We use Sig3D quite a lot for processing the images, which comes from Utah. CellML for encoding the cell models, as well as PowerView, Blender, Inkscape, and VTK for visualizing our results. This gives an overview of the software platforms that we're using for creating our models. So when we're looking at how we're going to bring modeling into the clinic, well, historically, currently not at the moment, but historically been based inside a hospital at St. Thomas's in central London. And the patients are coming through every day. The patients come in, they have measurements made, they are diagnosed, they are treated, and then they're asked to leave the hospital, and the process continues. So patients are coming in every day, every hour, and the throughput at the hospital is quite staggering. So if we're going to make models from patients as they're coming through this pipeline, we really need to work out how we can make these models at scale. It can't take us, or it can't take a PhD student to handcraft an artisanal whole heart model over the course of 3 years to do their one study. These models need to be high throughput, commodified. They need to be made in hours, not in days, weeks, or months as they currently are. The other question that we are faced with is that when we've made these computational models and we've presented these to our cardiology collaborators, they are very happy to see a movie. If we present them a result that moves and has colors, most of the time that gets them pretty excited. However, it isn't useful for treating their patients necessarily. And so we're really thinking a lot about how do we present our results to the cardiologists in a meaningful way such that they can make actionable decisions for directing the patient pathway. And then as we make more and more models, as patients move through this pipeline, we end up with virtual populations or kind of cohorts of virtual models that we've made. And how can we then use these virtual cohorts that we have, which represent particular patients with disease categories in virtual trials, so for drugs, devices, diagnostics, or procedures. And so these are the kind of the three ideas that we're thinking about when we're looking at how we can make the models from patient data and translate those into the clinic. So the disease we're very interested in, or the treatment we're interested in this particular talk, is cardiac synchronization therapy. So in the healthy heart, electrical activation starts with the atria. It propagates across the two upper chambers before activating the right and left ventricles. And so this leads to a rapid, synchronous, efficient, and effective contraction. About 1.1 to 2% of the UK population suffer from heart failure. And in these patients, there's a chance that the rapid activation system on the left-hand side of the heart will fail, leading to left bundle branch block. This means that the activation no longer is rapidly activating both ventricles at the same time, but the right ventricle is activated rapidly through the Purkinje network, the fast conduction system, and then the left ventricle is activated much slowly as the activation wave has to move through the myocardium. So this leads to a desynchronous, inefficient, and ineffective contraction pattern. And the way that this can be treated is with cardiac resynchronization therapy, where leads are placed, one in the right ventricle that we have here, and then another lead can be placed through the coronary veins into the left ventricle to activate the two chambers of the heart and augment that activation pattern, returning the heart to a synchronous, efficient, and effective contraction pattern. And this has significant health benefits. So there is a 30% reduction in mortality, 50% reduction in hospital admissions. So this is great. However, 40 to 60% of patients respond, leaving 40 to 60% of patients who don't respond. There's a large upfront cost for these patients, and that we also see the number of patients who are receiving this treatment is increasing each year. So there is a need to improve this therapy. And this is really where we have a model, a situation where we have a treatment that is relatively easy to understand, particularly if we compare it to certain types of drug treatments. We have a system where we have an idea about how to model that. It's an electrical activation or change in electrical activation. And so we felt that this was a system where we had a chance of using simulations to make or improve or influence patients' treatment. So we started off with thinking about how we're going to make models at scale. And so we started off in our particular center, we're very enthusiastic about MRI imaging, and we started off with MRI imaging. And this here is an MRI image from a patient with a pacemaker. Now, there are some pacemakers which are MRI, this is an MRI compatible pacemaker, but there are some pacemakers which have a less influence on the image. But we can see here a large artifact in the MRI from that device. This was on a list where we had the electrophysiologist, we had the MRI experts. They weren't able to get a good image. So while they could MRI this patient, the quality of the image for making a model was we would call that subdiagnostic. And so we're really, for a lot of the patients where we know they're going to have an ICD, which is the case for a number of the ventricular tachycardia patients, or for the CRT patients, particularly for the upgrade patients, we've switched to using CT imaging. So we have a nice contrast CT, and this patient has a device implanted. We can see the lead artifact here, so we do still have some artifact, but we do get a much crisper image, and this makes it much easier to work with. We then can segment the image, labeling the different chambers of the heart, as well as the myocardium, and using rule-based methods for describing the walls of the atria and of the right ventricle. We can then create surfaces and smooth that segmentation to remove some of the image artifacts from staircase effects that we might have. And then we can make a tetrahedral mesh to represent this patient's anatomy. And so this is tends to be about a 1 millimeter mesh that we create. We can then introduce physiology to our meshes. And so we have rule-based fibers, which are the same rule-based methods that people are using across all the centers, or most of the centers, where we're using the universal ventricular coordinate system developed by Ed and Gernard. We can then project the fibers into our hearts. Likewise, we can do the same with the Purkinje network to capture that rapid endocardial conduction layer. So when we think about making these models, we also need to think about quality control. So we can't just make these models and pump them out and hope that everything works. So we've provided some level of quality control checks. So for our segmentations, we produce images that look like this, where we have 5 different panels that you can look at quite quickly and get a feel to see if the segmentation is working reasonably well and we're doing a reasonable job capturing that anatomy. And we can look at that in a rapid snapshot. And so you can scroll through 20, 50, 100 patients quite quickly with this type of image to know that you don't have any massive gross failures to capture the anatomy. We have mesh quality checks, so we're looking at how regular the tetrahedral are, and we're trying to produce these for each of our patients. so that we can get an idea of the distribution of the mesh quality to ensure that we have that mesh quality. And also another area that's close to my heart is code quality. Working with Gernot is great because we have access to the latest versions of CARP and some of the exciting new technological developments that are available there. The downside of working with the latest software is that you need to continually check to make sure it still does what it was doing before. And so we have these verification checks that we can perform to make sure that the code is still acting as it should, which it does, but it's good to have these checks for confidence. When we think about wanting to scale this segmentation, though, we can't have just labeling these different regions from having someone go through each of these different cases. So we use machine learning for automatic segmentation of our 4-chamber hearts. We can then scale this up to give us these kind of virtual populations of hearts that we can make from standard CT imaging data sets in each of our patients. And just as a note, this particular imaging data set was made by Marina Strokey and my group, and all of these meshes are publicly available for download. So once we have our segmentation, we need to think about how we will go about meshing these segmentations. And so we'd like to automatically generate our mesh, and tetrahedral meshing has certainly come a long way since TetGen, that I was using during my PhD. So we now have a far greater ability to automate this process. But the area that we've really focused on is adding in standardized anatomical landmarks. So we have 24 different regions of the heart that we label in every single one of our 4-chamber heart models. These describe the myocardium, the left ventricle, right atrial myocardium, the pulmonary aorta, the aorta, the different inflows and outflow regions that we can use these for providing standard mechanics boundary conditions, as well as the valve planes and the planes for flow in and out of the heart, so that we can use this to calculate volumes in all the different chambers that we have. And so by having these standardized anatomical labels across all the hearts that we make, and I think we have 40 or 50 of these now, we can then very rapidly apply different boundary conditions or rules to our patients for doing lots of different simulations. And so we can generate these standardized virtual cohorts of different meshes with all the different regions labeled in the same way and have that as a standard labeling for all of our cases. And this, again, is just key to moving into the simulation at scale. You need to have these standards for your virtual cohorts. For the Purkinje network, because we have the universal ventricular coordinate system, we can use these generative methods for creating Purkinje networks, and almost definitely be moving on to Ed's new method that he was presenting yesterday for our cases. But we can project these Purkinje networks into the multiple 4-chamber hearts that we have, so we can create these virtual cohorts of patients with synthesized Purkinje networks throughout. And then we need to move on to simulation at scale. And so we've been using the reaction iconal equations that Gernot described in his presentation earlier in the week. And we can extract out the boundary conditions for these models, because most of the patients we're dealing with are patients who have a pacemaker implanted, so a right ventricular pacing lead or a defibrillator implanted, and they are going to receive a resynchronization device upgrade. So they're going to receive a left ventricular lead. One of the benefits of working with these patients is we know where the right ventricular lead is, and so we know where activation is going to start from. So we can describe this as a boundary condition for our models. And then we can use this to simulate multiple different activation patterns for different anatomies and different leads. And as Gernot noted in his presentation, differences in anatomy can have a significant variation in the activation patterns, and that we also here see similarly the combination of the different lead position with the different anatomies can lead to a gross variation in the activation patterns that we see in these patients' hearts. We'd also then like to look at how we can couple the electrical activation with our mechanics models. And so we have our activation pattern that we have from reaction iconal. We're not, we have yet to publish a full closed loop circulatory system. It is something we're looking at, but we do at least account for all 4 chambers. As Olaf pointed out, we have a preload for both the right and the left ventricle in the form of pressures in the right and left atria. We also have Windkessel models representing the systemic and pulmonary circulations. We do have an afterload model that we can tune for these individuals. And certainly I would agree with Olaf that closing this loop to make closed loop systems is certainly going to be important going forward, particularly when trying to make longer term predictions. The other boundary condition that we've found to be important, as was evident from Olaf's talk, was the pericardium. So we have normal spring resistances with a graded penalty method for representing the pericardium in our model. We also have an isotropic passive material properties for the atria to capture the effect of the atria on the ventricle. At the moment in these simulations, we don't have contraction in the atria. That's something that we're looking to add in. We have a transversely isotropic material in the ventricle, and this is going to follow the fiber orientation that we've described previously. And we have an active contraction model as well for driving deformation. So for active contraction, we have our contraction model, and we have that we've made, which is biophysical, and we also have our model, which is a phenomenological one. The results I'm presenting today are phenomenological. The phenomenological model, despite having many shortcomings, is very easy to tune. And so when you have expensive simulations, it's a great way to get the model to be in a working space that you can then use to add in the more biophysical models. The biophysical models we've created capture the effect of calcium binding to troponin C. This then allows troponin I to associate to troponin C, allowing tropomyosin to move out of the actin groove. This then reveals the actin binding sites. The cross bridges can then move from an unbound to a bound state, completing the power stroke and generating tension. And we're very lucky to work with John Kentish at King's College London, who had access to isolated human myocytes, and we could perform force length measurement or force length calcium measurements here at steady state in these myocytes and use this to constrain the thin filament kinetics. And then we could do length step measurements, which cause a detachment of cross bridges, and then we can look at the reattachment of those cross bridges to characterize the cross bridge kinetics. However, all of these measurements were made in isolated myocytes, and that these were skinned. And so it's very important when looking at experimental results to remember that a skinned myocyte is not the same as an intact myocyte. And so we had to recalibrate our model with driving it with an intact calcium transient to be able to generate physiologically plausible tension transients from intact muscle in humans. And this gave us our completed intact muscle model for simulating contraction in human trabecula, or in human myocardium. And we can then start putting this all together. We can have these activation patterns from our Purkinje network leading to contraction patterns, and we start to simulate the left ventricle and right ventricle pressure volume loops. And what's nice about these simulation results, as we also saw in Orlov's results, is that you have this nice basal motion where the base of the heart is contracting down, it's pulling the atria down, so it's filling the atria up with blood, the heart then recoils, and the atria then allow to fill the ventricle through the conduit phase, and then we'll be very excited to add an atrial contraction, allowing that booster phase to be encountered. So this is really where we're moving to with the 4-chamber heart models. And so when we think about simulating these contraction models at scale, it's all well and good simulating one, but when you want to simulate virtual cohorts, you need to start thinking about some of the practicalities. So we have access to currently Archer 1, which is the UK's national supercomputing facility. Archer 2 should have been installed in March, but turns out that was a bad month to have a computer shipped from America all the way to the UK. So we're hoping that it will come online in November. But just as a calculation, so we've been thinking for a long time about, can we make a model that can solve and that we can actually solve these problems at all in a reasonable time frame. So our simulations take about 512 cores in approximately 24 hours. And that's okay, that's tractable, we can do that. And obviously everyone's cost per core hour will be different, but if you're paying 1 cent per core hour, you're looking at about $122 per simulation. And so when we are looking at doing maybe 30 to 40 simulations per patient, cohorts of 50 to 100 patients in a standard study, these numbers really add up. So it's not so much that can we solve these simulations, can we afford to solve these simulations? Because it is getting reasonably expensive at the current rate. More recently, we've been able to accelerate some of these simple solvers. So we're now down to about 6 hours on a 64-core machine. This is a desktop machine that we have, or that people can buy with the new AMD chipsets. And also, luckily, HPC costs are decreasing. So there's a 20% decrease in cost for the new HPC in the UK, at least. So we think we can do this, but I think this is something which we are going to have to start thinking about, is that we can perform these simulations, but the cost of simulating these models is not negligible. But you can then have nice movies like this, where you know, the standard simulation cost, you're looking at a couple of $1,000s worth of movies. So it's something to consider. But it does show that we can simulate these kind of virtual cohorts of patients at scale using electromechanics simulations. So we now have these cohorts, and we're starting to think about what we can use a cohort of models. So instead of just having one patient, as we have lots of patients, what does this allow us, or what are the types of questions we can start to answer? So we've created a cohort. We have a cohort of heart failure patients that we've published. Now we've created a healthy control cohort, which we're now analyzing. What we can do with what we've done in the healthy control cohort is we can register all of these hearts together, and we can then do a principal component analysis of the shape to work out the different modes of shape which describe the patient's hearts. And we see here, when we look at our different components of shape and what proportion of variance each one of those modes explains. So mode 1 is 30-some%, and then we come down to mode 18, which is kind of less than 1%. And about 90% of the variance of shape can be explained by the first 9 modes. And so we can start looking at these modes of shape and these 4-chamber hearts and start thinking about what modes are affecting different parts of the heart. So mode 3 is affecting the atria. Mode 4 has a big impact on the right ventricular apex, and so on and so forth. So we can start to think about the different types of shape that we have in these patients and how that shape then influences the mechanics models that we're looking at. So we had, in our case, we had 18 modes describing the shape, and we wanted to see which of these modes had the biggest impact on the pressure volume loop. So we can describe the pressure volume loop as well as the electrical activation of our models in terms of volume and pressure features. So volumes are things like end diastolic volume, end systolic volume, ventricular mass. Pressure measurements, which we have, are peak pressure, time to peak pressure, maximum rate of pressure development, maximum rate of pressure decay. And electrical measurements, we have things like the QRS duration, or the time for the left and right ventricles to activate, the activation time for the left ventricle or the right ventricle, and we also have the activation time for the 10th to the 90th percentile of the myocardial mass to be activated. We can then look at, how we present these results is we have a donut shape here, and each of the modes 1 to 9, are represented by each of these segments and by their color, and this represents the portion or the fraction of the variance in that phenotype, which is explained by that particular mode. And then we've lumped all modes 10 to 18 into one gray region, because assume they don't have a massive impact. And then we have multifactorial modes. This is where if both mode 1 and 2 have a synergistic effect on a particular outcome. So we can look at generating these for the right and the left ventricle and looking at the kind of global sensitivity and identifying which shape modes are having the biggest effect. And one of the reasons we wanted to do this is that the higher shape modes, so kind of modes 1 and 1 to 4 or modes closer to 1, are more likely to be preserved across different imaging modalities. Whereas the higher modes, they're going to require a higher resolution image and are potentially more likely to vary between different imaging modalities. So we use cardiac CT, which is a 0.5mm resolution, whereas if we used MRI, which is more of a 1mm resolution, we would have a poorer characterization of the higher shape modes. And if we'd used echo, that would have been lower still. And what we see is that many of the volume-based measures all are relatively dark red, and the dark red corresponds to the higher modes. These ones are likely to be relatively consistent across different imaging modalities. But when we move on to pressure measurements, so things like dPDT max, this is much more dependent on mode 9 and on even higher modes. And that becomes even worse when we move into the right ventricle. We also see, and this was a surprise to us, that the activation times are very dependent on the higher modes and on multi-mode factors. And so they weren't solely dependent just on the bulk early modes, which describe bulk shape, but some of the subtleties in that shape became important. And so this provides us a way of determining what effect different imaging modalities might have on our shapes, and also highlighting that we need to include often potentially much higher modes than we'd expected for capturing functional variation as opposed to capturing anatomical variation. We've also been using these models to study a new type, or recently newly proposed form of cardiac synchronization therapy, so HIS and left bundle CRT. So in a normal heart, we have this activation, as we said in the first instance, we have this Purkinje network, which is viable. We have our left bundle branch situation, and then we have two forms of CRT, which has been available up until now. So one of those is conventional CRT, where we access the ventricle through the coronary sinus. And then the other is where we have here we have a leadless pacemaker on the endocardium. So these are two options that have been evaluated at the moment. But there's also an option to do left bundle pacing. And so we just pace the left side of the Purkinje network distal to the, where hopefully any break that's caused the left bundle branch block. And so we can recover that physiological activation pattern, or we actually pace the bundle of His, so we activate both the right and left pacing. And so the doctors are exploring these often in smaller studies, and larger studies are proposed, but our cardiologists were very interested in understanding what type of patients these particular types of treatments would be most likely to work for, and would they be manifestly better than conventional and or endocardial CRT. The other question they had was that, and this is a clinical trial design that's been proposed and has been carried out, I think it's been driven by Imperial College in London. You have options of, where we start with the intrinsic activation, we have a QRS of 92, so it's a healthy activation. You have selective captor, where you pace just the Purkinje network or just the His network, and none of the surrounding tissue, and that's going to give you QRSs which are comparable to the intrinsic. Alternately, you can do what's called non-selective pacing. This is where you pace the myocardium and then indirectly capture the His or the left bundle. And this gives you a wider Q restoration, but there's a question as to if this has a important difference between these different, when it's delivered with selective or non-selective activation. In this particular study, we were just looking at electrical measurements. And so we wanted to look at different ways people propose for evaluating acute response to CRT. One of those is a change in QRS duration. One was the standard deviation of the activation time, which we'd like to see less reduced. We'd proposed that you could use the 10th to the 90th percentile of the activation time, and we'd like to see if we could reduce that number. And then there is the total left ventricular activation time, which also people would like to see was smaller. Now, one of the challenges we've had in our models previously is we don't historically simulate the QRS duration, and that the CT images we have often don't include a full torso. But for this study, we were able to register each of our models inside a torso, so that we could then simulate the ECG or the 12-lead ECG to be able to get an estimate of what the QRS duration was, so that we could calculate this based on a simulated ECG as opposed to just the total activation time, which is what we've done previously. So we have the question. We have 24 patients who've had CTs, who've made models with Purkinje networks, with electrical activation, and we'd like to see how they respond to the different treatments. So our baseline, here is our conventional CRT, and then we can look at all different permutations that we could have for each of the treatments. And what's nice is that we're looking at these permutations in the same patient set. So we're not comparing, so every patient can act effectively as the same control. And so here we see that if we have endocardial pacing, we have a reduction in the QRS duration, that lateral pacing seems to be, or tends to be, better than septal pacing, but that we do have a decrease in activation time across all the different indices that were proposed. Then we have His bundle pacing, and consistent with what we'd expect, we see that non-selective His, which is our first bar here, has a slightly longer activation time than selective His bundle pacing. But again, both of these were shorter across all of the different indexes than endocardial pacing, except for the right ventricle, where the selective His and non-selective His both had or the non-selective His, sorry, had a prolongation of activation time, and that was due to the early signs of activation in the right ventricle in that model. And then we had just left bundle pacing, and again, the selective and non-selective, we see the same pattern that we'd expect. But what's noticeable with the left bundle pacing is this is only beneficial in left ventricle activation time and can cause a prolongation in QRS duration, as well as right ventricle activation time and the standard deviation of activation time. So this was, for us, was a relatively, not terribly complicated simulation to do, but it was very interesting to the cardiologists. And this is just simple messages that they can take home. So we see that His bundle pacing can be more synchronous than conventional endocardial CRT. Left bundle pacing will synchronize the left, but not the right ventricle. This may be expected, but it does mean that if you don't see a change in your QRS duration with left bundle pacing, it doesn't mean that the treatment's necessarily going to be ineffective. And that, consistent with as expected, we saw that the non-selective pacing was going to have a wider activation times than selective, which is possibly more a sanity test than anything else. And so the other area that now that we've been looking at His bundle pacing is how can we deliver it? And so this was a case study that we have put in and is currently in review, where we were using a left endocardial pacing catheter. And let me find this here. So we have our coronary sinus lead and our RV lead and our roving catheter, which has been put in the septum. We're pacing the left bundle branch, and we can then compare the curious durations we have. This is a standard RV pacing is about 172 millisecond. We have bi-V pacing, which is down to 132 millisecond, and we have left bundle pacing, but in this left bundle pacing, we also included a right ventricular pacing lead, and that brought us down to a curious of 106 milliseconds. So we are seeing an improvement in the curious duration when we are pacing from the left bundle, which is in excess of what we would see with biventricular pacing. And so what we're now, what we've been doing with this particular study was part of a wider study. We were trying to optimize the delivery of endocardial CRT. So endocardial C has been historically very difficult to deliver. If you leave a lead in the left ventricle endocardium, the patient has to be on continuous anticoagulants to stop the stroke risk. Whereas EBR systems have made a new electrode, which is, as you see here, 9.1 millimeters long, and it completely endothelializes, significantly reducing the stroke risk, allowing patients to be permanently and safely paced with a left ventricular endocardial lead. So the system itself is made up of 4 parts. We have a co-implanted device. This is a right ventricular pacing lead. So this is why we're working with our CT images. We have a electrode, which is again about 1 centimeter long. We need to have an optimal location for this, but it has to be unique in each patient. We have a battery that gets implanted, and this is a secondary battery, and its life supply will depend on the relative efficiency of the power that's delivered from the transmitter through to the electrode. And then we have this power transmitter, which is going to be implanted between the rib spaces and deliver ultrasound to this leadless electrode with each heartbeat. But it needs to be, but we need to be ensured that the electrode is located in a good position for that transmitter, but that the electrode is also located in a good position for delivering effective CRT for this patient. And so we have to optimize both of these systems at the same time before we implant them. And that's really where simulations and prediction come in for guiding this therapy. So where would we like to place? So we have 3 things. 1, we'd like to pace out of scar, we'd like to pace in late activated regions, and we'd like to pace in an area that's covered by the transducer. And so our process for doing this is we work out where to put the electrode, which would be out of scar and in a late activated region, and then we determine where best to put the transducer so we ensure that we're covering the electrode once it's implanted. So we need to avoid pacing in scar, and this is for 2 reasons. The first of these reasons is that if you pace in scar or in slow conducting regions, you have a poorer outcome for your patients. And the other reason is that, certainly from simulation studies, we've shown that if you pace close to infarcts in CRT patients, both endocardially and epicardially, that you can, if you pace close to scar in patients epicardially, you see an increase in the arrhythmogenic substrate. We also know that we'd like to pace in late activated regions. So if we pace in late electrically activated regions, we see a better response. And also if we pace in late contracting regions, we see a better response. So these are what inform our decision on where to pace these patients. So to work out where the patient's late contracting regions are, we made our own software for doing CT image processing and feature tracking. And so we can track the motion of the heart for each of these patients and generate endocardial strain maps. We also have quality control reports for these cases where we can show frame by frame for the CT, the location of all the different walls of different chambers to make sure that they're appropriately tracking the image, which we found to be easier to do in an image, in a static image, as opposed to doing it in a movie. We'd like to identify where scar is in these patients, and so for this we use perfusion CT. This is an example of a patient's heart where we have the red regions are well perfused and the blue regions are poorly perfused. The basal and mid slices and inferior lateral, and so we have a basal mid inferior and lateral mid scar. And in this particular patient, we also had MRI from before they'd had their lead implanted. So here we have from the basal short axis, we can see they have an inferior scar, and that from a mid short axis, we have an inferior and lateral scar for this patient, giving us a consistent result from MRI and our CT for these cases, gave us some confidence for using this information. Another problem which we had highlighted to us by the device company was that their electrode, while small, does have a barb at the end of it, which is 3.6 millimeters long. And so we really don't want this to go through the wall of the heart. So the wall of the heart where we implant this barb needs to be at least 5 millimeters thick. So we can generate these wall thickness maps for our patient's hearts, and we can then project those onto the AHA segments. So we know that we don't want to be placing in very thin regions, such as here we have the posterior lateral region, where the wall was particularly thin. We'd then like to say, can we predict where the late activation region is? So this again comes down to the workflow that we've created for making those virtual patients. We have our CT derived anatomy. We have a 12-lead ECG for each of these patients. And we've also looked at making, and then we can add in the rule-based fibers for these patients. But we've also looked at studies where we've developed a rule-based electrophysiology model where we can include a fast endocardial conduction layer. And we showed that this was essential if you wanted to really be able to recover the local activation times as best you can if you only have the anatomy in the 12-lead ECG. So this provides us with a very rapid way of generating predicted activation patterns in patients just from the CT and the 12-lead ECG without any additional equipment. And this fits very nicely within the clinical workflow. So we can then make these models, we can predict the activation patterns, we can predict the conduction velocity, which we tune for these individual patients, and then we can use this model to predict the different activation patterns that we'll achieve when we pace from different regions and identify where we'd best like to pace in these patients based on their activation patterns alone. And again, this gets presented in these AHA segments as we have here in the bottom corner. So we've come up with 4 different ways of working out where to put the electrode. We have the perfusion image, which tells us where not to pace. We have a wall thickness measurement, which again tells us where not to pace. We have our electrophysiology simulations, which are telling us where we'd like to pace. And then we have motion tracking, which can tell us where we'd like to pace as well. And we present all of these to the cardiologist. It's also worth noting that in our patient group, these are not well patients. These are patients who are having an experimental, those patients who have been a relatively new therapy, and the indication for this therapy is often that they've had to fail their previous therapy or that they were unable or ineligible for conventional CRT. So these tend to be not the most well individuals. So for this reason, some of these patients will have severe kidney trouble, and so we can't get a good contrast image. So we cannot always use all of our motion tracking or our perfusion results. They might have bad image quality if there is too much artifact. There are a number of things that can go wrong. So by having these 4 different measures, we can always provide at least some information. We're reasonably robust to telling the cardiologist where to pace. So we have a pre-procedural discussion with the cardiologist, so we involve them in the discussion. It's not a simple model or an image processing guidance system. We provide the evidence to the cardiologists rank which of the locations they would like to pace from, and then this is what we present to the cardiologist in the procedure. Once we know where we would like to pace the electrode, we can then go back to our transmitter and look at how to optimize the transmitter location. Because we have these cardiac CTs, we can pull out the location of the heart as well as the rib cage from the images. We can then do virtual implants of the power transducer in different rib spaces. So we can say, identify where that power transducer will be located, if it's put in the 6th space, the 5th space, or the 4th space. And we're told which of these spaces are eligible based on the ultrasound imaging of each of these patients. And then once we have this, we have an energy dissipation equation for the ultrasound transducer provided to us by the device company. And that allows us to estimate how much energy will be delivered to the endocardium and what the distribution of that energy will be. So from this, we can then look at our different energy distributions to work out which location of the transducer is most likely to cover the electrode location. We can then feed this information back to the cardiologists for when they do the implant. So the workflow is that the patient comes in, they have a CT image, they have an ECG made. We then do our planning and our analysis, and this, for us, we've done this in as short as 48 hours. It's not as fast as we would like it to be, but it does make it tractable with these timeframes that we have within the NHS. We then can, working with Siemens, we can register the overlay targets that we have derived from the images and from the models that we've discussed with the cardiologist onto their fluoroscopy overlay system. So we can put these targets onto the fluoroscopy, which is presented in front of the cardiologist during the procedure. And these look like regions where they're trying to put the catheter on the red square or on the orange square, depending on which ones they can access. And this provides a very real way that we can communicate what we need very real way we can communicate the results from the model to the cardiologist in the procedure in real time. And so because this is working with the Siemens system, It means that as they move the C-arm around, so the fluoroscopy image can move, the registered image also moves with that C-arm, so it remains in place during the procedure and is updated in real time. And so this work has led to a number of case studies. And so the first one was...
Excuse me. Can you just try to wrap it up for the sake of time to...
Yes, sorry. Yep. So we had two case studies, one where we'd showed that we could do this in one patient, and more recently in the same workflow, we've been showing how we could actually deliver a fully leadless defibrillator using this system by combining leadless right ventricular leads and ICDs. And this was a team of people who made this possible. In particular, Aldo Rinaldi and Ronak, who have helped us with the CRT and with the CT imaging, Marina and Cristobal and Angela, and Jose, who have then helped us a lot with the CRT modeling, as well as our external collaborators. Thank you. I'm happy to take questions.
So one question. Okay, so thank you very much for the broad overview, including very interesting applications. I would just to keep the program, I would just recommend one question, and then to postpone all the others. Please don't be, let's say, don't refrain to the coffee break, while Professor NIEDERER will be available in room C for question and discussions. So if anybody has one pressing question, please go ahead. Okay. So there is a question from Mitchell. I just read the question. I enjoy your talk. So since you have such a large cohort of data and information about the shape modes, it seems like you could construct an emulator reduced order model for the expensive model you have, say using Gaussian processes. It is something your group has considered?
Yes, so we did the global sensitivity analysis using Gaussian process simulators. So I didn't go into the details, but we used a Gaussian process simulator trained to our data set, and then used that to perform the global sensitivity analysis, which is a variance-based method.
Right. Okay. So one last question by Professor Trajanova. Please, Natalia, go ahead.
Steve, this is fantastic. Thank you very much for this awesome talk. I have a question for you. Throughout your presentation, you would refer to, we present this to cardiologists, or we talk to the cardiologist. What are your plans for, like, not just bringing to the workflow locally, but how do you envision this growing to actually a clinical trial? If this is to become really a methodology that's used by other centers, it has to be demonstrated that it has some advantage over current methodologies to be for market acceptance, if you will. Do you have any plans for that?
Absolutely. I mean, I think at the moment we've been working, so we started the project with that in mind, and we've been working very closely with Siemens on the simulation guided therapy. And so I would have to look at the contracts and exactly what they say, but we would look at exploring if they would be able to support that to move it to multiple centers. And we've been developing the software to work alongside on the Siemens basically cath lab guidance platform. So it links in, the software we have will link in with the Siemens guidance platform. And so we can then look at moving that to other centers. It's something that we're interested in doing. At the moment, our trial, like so many other people's trials, has been put on hold. The trial we have is not was not deemed COVID related or absolutely essential, but we've got our first patient post-COVID or halfway through COVID, depending on how you look at things, that we'll be starting this trial up again. So once we've completed the trial, we'll have done our 20 patients, we'll have shown that it's safe, that what the delivery is, then that will provide us with a platform where we can move on to recruiting more patients.